The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always. Welcome back to the Virtual Curbside. This is your host, Paul Wirkus. We're talking this month about hearing loss in children. We're very fortunate to have Dr. Albert Park and Dr. Adrienne Johnson here from the University of Utah, Department of Pediatrics, and we've learned a lot over the last 2 weeks. We've talked about the technologies involved in establishing hearing loss in children. We've talked about the diagnosis and the things that go into making the diagnosis of hearing loss. This week, we want to talk about the interventions for hearing loss. So welcome back, Albert and Adrienne. Albert, you want to mention your disclosures again?
Sure. I am on the scientific advisory board for ACCU, which is a company that's involved in gene therapy. I'm also on the scientific advisory committee for the National CMV Foundation. And then lastly, I have some funding through NIH as well as from the University of Utah. But I think none of these issues are relevant to the discussions we're having in terms of disclosure.
Terrific. Well, let's dive right in. We're going to attack this topic by topic because I think there are different approaches. Some approaches are going to be different for some children. Some have overarching importance. We talked a little bit both of the last 2 weeks about CMV. So what's the role of CMV in congenital hearing loss?
So, cytomegalovirus, it's interesting. When I learned about this as a resident to pass my in-service exams, I probably saw maybe one child every few years with this condition. And so I definitely had seen it, but really didn't realize how important it is for hearing loss as well as for child development. And some of my discovery of this was having a chance meeting at one of our EDDI conferences, talking to the NIDCD, one of the deputy directors there, about the lack of CMV research. As I've learned more about it, now I probably see 3 or 4 children a week with this condition. So to backtrack, it's the most common non-genetic cause of pediatric hearing loss. And so it's sort of been a stepchild and that has been underappreciated. There's a lack of awareness, yet it has huge implications for the family and for the child. The other challenge is that it has to be detected early. It's a congenital infection. So cytomegalovirus can cause an infection just like rhinovirus or adenovirus or others at any time in life. But the hearing loss occurs during pregnancy, where the mother, unfortunately, either through a reactivation process, re-exposure to a new strain, or gets it for the first time, or pass it to the unborn fetus. And it can cause a whole host of complications or sequelae, but the most common is hearing loss. There's been a lot of work, and Utah actually has been a leader in many respects, and that it's the first state in the country that implemented a statewide early CMV sort of testing or screening program. And there's been data now through David Kimberlin's group and others that have shown that if you intervene early with antivirals for those with more severe infection, you can have a positive impact in terms of their neurocognitive and their hearing outcomes. So this has been a very exciting time in terms of we are learning more and more about how we can better detect these conditions as well as do a better job in sort of treatment. In the country, there's even talk about universal dry blood spot screening. Here in Utah, we have actually gone from a hearing targeted approach to more of an expanded target approach. And this is really a collaboration with pediatric neurology, infectious disease, audiology, speech and language, as well as the Utah Department of Health and Human Services, where we look at about 11 different criteria. For instance, maternal history of CMV infection. We look at the central nervous system. Small for gestational age is one, thrombocytopenia. We look at these factors as sort of triggers for testing. And this is really a tribute to our providers, our family practice and primary care physicians who've been very helpful with our pediatric audiology colleagues in doing a really good job in identifying these children. I think we do a great job We've published on this where I think we do for detection of more severe CMV infection. I think we do just as well as, say, from an approach of universal, but with a much lower cost and logistical sort of load or burden. And so I think now we're detecting probably one or two children every few weeks with this, and we have a really great integrated program in working up these children. So that's one of the sort of, I think, triumphs or successes, as well as genetics that we've looked at in terms of improving this process.
The diagnostic modality we're using in Utah is mostly urine screening, correct?
So you could do either saliva or urine. Saliva has the obvious advantage that it might be easier to get a saliva sample from a newborn than from urine, but the challenge there is that there's about a 15% false positive rate with saliva, presumably due to breast milk contamination. And so I'd say well over 90% of newborns who are tested in Utah undergo urine because, if you do a saliva, it's positive, then you have to have the child come back within that 3-week period. That's logistically can be very challenging. So in many cases, I think we just do the urine. The other way to diagnose these children is, because again, you want to identify these in the first 2 weeks of life. But another way that we've been very successful in diagnosing the older child, and this comes up not infrequently, you may have a 4 or 5-year-old child who is found to have a sensory hearing loss because they failed their kindergarten testing. We're able to, with a collaboration with Utah Department of Health, to obtain the dry blood spot samples. So the dry blood spot samples in Utah are kept for about 7 years. And this again is with a collaboration that started with Harper Randall, where she felt this was a good idea that we can then do CMV PCR testing. So these are children who all undergo, the heel stick for metabolic workup, cystic fibrosis, etc. We keep it for 7 years because in a 5-year-old child who has an unexplained hearing loss, we can obtain that heel stick, run a CMV PCR test, and evaluate and test for CMV. We've, I think, identified about 20 or 30 children that way, and that has huge implications in terms of knowing their prognosis. We don't have to go through a diagnostic odyssey for other testing, and so that's been very successful.
Is the change in number of cases of CMV that you're seeing, is that a matter of true change in prevalence or a change in surveillance?
So we think that the prevalence of congenital CMV in newborns is about 0.6%, but it's a lot higher in the developing world. So if you were born in Argentina or you're born actually in Korea, you're going to have a slightly different prevalence rate. But in Utah and most of the US, it's probably about 0.6%. That number probably has not really increased over the years, but what's happened is the awareness or the testing is. So in Utah in 2013 is when the statewide early hearing targeted screening program started. We went from essentially a handful of children identified to probably about 15 or so children a year. And then in 2019 to 2020 is when we started going to expanded targeted testing. And I think we've doubled or tripled that number. So it's not that the prevalence has increased, it's just that we're doing a better job in identifying these children.
And when identified, how helpful is antiviral therapy?
Good question. So the Red Book recommendations, which just came out, I think, last year, have sort of provided a little bit more flexibility. Before that, you had to really identify these kids, work them up to determine severity of their disease, to offer antivirals by 4 weeks of age or 1 month of age. That's a really tight timeline, really tough on everyone to do that. But yet, a tribute to my colleagues that we have been very successful with that. But with the new Red Book recommendations, that's been pulled out to 3 months, and that's based on some of the work in Vassen's group, as well as we've been able to extend or provide or recommendations not only for those with central nervous system, more severe congenital CNV disease, but we also are having recommendations for treatment in children with isolated sensory hearing loss. Why do we do this? Well, we do this because the data suggests that this can have a positive impact in reducing the sort of effects neurocognitively on speech and language, as well as helping with hearing. The problem with congenital CNV infections is that one, it causes hearing loss, but not only that, but in many of these children, especially if they're born with hearing loss, there's a high chance, about 50%, that they'll go on to develop progressively worsening hearing. What's also a problem with this condition is that they may have hearing loss in one ear when they present, but then the contralateral ear is also at high risk. And then some of these children who may be passing their newborn screening, even get diagnostic hearing testing early on, which is reassuring that it's all normal, will then go on later in life to be found to have late onset hearing loss. So big problem. And fortunately, antivirals, if we catch these children early enough and use judiciously, can make a big impact. But again, it's only a piece of the puzzle, that there's other things that we need to do in terms of early intervention, hearing aids as needed, potentially even cochlear implantation.
Well, let's talk about some interventions. Adrienne, you mentioned a couple of weeks ago that the decision whether or not to intervene really does belong with the family, given the best information that they have. But there are several things that you can do to help improve hearing. Tell us about hearing aids. What's the role for hearing aids? How do they work? What are the limitations? And what's best?
Yeah, so really the type of intervention depends on the type of hearing loss and the severity of the hearing loss that a child has. So there's different options that we have, and sometimes families can choose between a couple of different options. So when we think about hearing aids, most of the time we're thinking about a conventional hearing aid where the hearing aid sits behind the child's ear and there's an ear mold in the child's ear. So these hearing aids work for the majority of kids. They work for kids with very mild hearing losses all the way up to having more severe hearing losses. And what that essentially does is the audiologist has special equipment where they program that hearing aid according to that child's hearing loss. So it's not one size fits
Mhm.
all. It's according to the hearing testing, and it's amplifying sound that is not audible to the child without the hearing aid in. So there's a measure called the Speech Intelligibility Index, or SII, and it's a metric that is used to evaluate how much of a speech signal is audible and usable for a child. So the audiologist will determine what the SII is. It's expressed in a percentage from 0 to 100. Typically, kids with an SII of 80 or higher are not good candidates for hearing aids because most of the speech signal is audible for them. But 80 and lower, it definitely is something that would be recommended for hearing aids. That being said, sometimes you have a child who has a 0% SII who has a more severe to profound hearing loss. And we know that conventional hearing aids are not going to be able to provide enough amplification for them to gain access to speech and language. And in those cases, that's where a cochlear implant would come into play that we will talk about a little later. But a conventional hearing aid is just amplifying sounds acoustically for children to be able to hear. There's another type of a hearing aid that's called a bone conduction device. So this works a little differently. It's a little processor that is worn on a soft headband, typically placed on the mastoid behind the ear. And this works via bone conduction. So this is for babies and kids who have conductive hearing losses. So this is more microtia atresia, kids with chronic otitis media or chronic middle ear dysfunction, or they have some reason why they can't utilize a conventional hearing aid. And so typically kids will wear a bone conduction device, either unilateral or bilateral, until they may become surgical candidates for a bone conduction device that Albert can talk about the surgical options for these children.
Albert, why don't you talk about that now and then we'll move on to cochlear implants. So, what's the next step to the bone conduction implants?
As Adrienne mentioned, I think the most common scenario is like an atresia or microtia or chronic otorrhea, those sort of issues. I do want to make a little plug for Sarah Kina and Quinn Orb. They have a multidisciplinary microtia clinic, and so that involves children who unfortunately have absent ear canals, as well as auricles. And I should also mention Amy Faust, who's pediatric audiology. And so they see these families together. And the reason I'm mentioning is that I think it's more than just, I mean, the hearing is very important, but they also address the cosmetic issues too, which I think is really important for a child's self-esteem, especially as they get into the kindergarten ages where children obviously are very perceptive. And so they're very much involved in that, as well as our team is too, in terms of trying to provide care. But in terms of surgical osseointegrated implantation, the FDA approval is for about 5 years of age and older. There's a number of different devices that are out there. I think the advantages to the families is that I do think it provides better hearing sort of quality or amplification compared to the non-surgical Bahas, because you actually have a piezoelectric device that provides excellent amplification even on high frequencies. And so I think the fidelity in the hearing is quite phenomenal for that. But I think, again, it's a very much an individual decision in terms of whether a family wishes to proceed with that sort of surgical implant. Obviously the risk with that is the surgery, the anesthetic, those sort of issues, as well as the need to maintain those devices. But that is certainly available for families.
Tell us about cochlear implants.
It's been sort of a revolution since when Dr. House from the House Ear Institute placed the first single channel cochlear implant. I think it was back in like the 90s or so. Now we have multi channel cochlear implants. So, the interesting thing about the cochlea is that it's tonographic. So, the cochlea is shaped like a snail. If you actually unwound it, made it into one long sort of tube, different portions of the cochlea are responsible for sort of sound transmission. So the portion that is sort of at the base, or called the basal portion of it, is actually associated with high frequency hearing. And then as you curl up to the center portion, or what's called the apical, that portion is associated with lower frequency. And so the reason I'm mentioning that is with electrode placement. So when you're placing a cochlear implant, you're actually placing the electrode within the scala tympani, which is one of the fluid-filled chambers within the cochlea. Manufacturers all have different numbers of channels, but each of these channels are responsible for providing sound amplification of different frequencies. Now, the first one was just a single channel, but now we have devices that have multiple channels. This provides, I think, an improved speech perception by being able to then essentially you're converting a sound sort of through a microphone to an electrical signal that's then directed to the what's called the spiral ganglion portion that then is then transmitted to the auditory nerve. And so this provides sort of frequency specific sound, which is critical, I think, for language and speech acquisition, especially for our recipients. Does that make sense?
It does. It does. It's a different kind of sound perception you would get from it then.
Yeah, I mean, our ear is an amazing organ. It provides sort of this incredible sort of ability for us to both understand spoken language, but also appreciate music. It enables us to discriminate both what we're interested in hearing and sort of filter out background noise. And these are things that, although a cochlear implant is incredibly impactful, we have children oftentimes who are mainstreamed in school if you implant these children early enough, but it still doesn't replace a normal ear. We still don't have the technology to do that. So definitely it has a role, but it's a role in which we have a child who, if we want to provide them access to language as well as to sound, and we can't provide that with conventional hearing aids or other means of amplification, that's when we start looking at cochlear implantation. And the classic is a child who has got bilateral profound hearing loss. And in those situations, we really want to intervene really early. FDA approval is for 9 months of age. That seems really early, but again, if we're going to achieve the optimal speech and language for these children, we can't wait. Even waiting 18 months of age or 2 years of age really has a negative impact on their ability to achieve optimal speech and language. And I'll see children, unfortunately, who are 4 or older, and at least if the family's goal is for their child to be able to communicate through speech or be able to hear speech, it's not attainable. You have this sort of limited period of plasticity, a critical period. The child needs to be introduced to sound and language if they're going to be able to acquire language.
What are the limitations? What's the lifespan of a cochlear implant? Do we expect that to last the rest of your life? Are they replaceable at some
That's the
point?
goal. I mean, the goal is that they will last, for the lifetime. And I think the fidelity and the technology is pretty amazing. That being said, unfortunately, you might have device failures. Fortunately, that doesn't occur often. But in those situations, yes, a cochlear implant electrode may have to be replaced. It's not a perfect device. I think it relies a lot on patient and family motivation. They have to see the audiologist regularly afterwards. They need to really use it. We look at wear time as a factor. We look at a lot of other criteria. And, in a child who's otherwise normal, who unfortunately has profound loss, but is in a situation where maybe the family doesn't have the means to see the audiologist. Maybe they don't have the motivation. Again, if you wait too long, those families do not do well with these. So you need to actually look at a number of different factors if you're able to achieve success with these. But if you are motivated and you follow those recommendations, these children can do incredibly well. I mean, you can see children in school, you never know that they have implants because they do so well.
Right. No, I have some of those patients. Tell us a little bit about the overarching role of early intervention.
When we think about early intervention, we've mentioned this 136 several times during these last several episodes. And I think it's worth talking about again because this really is what drives us and helps make our kids successful. Is that screening must be completed by 1 month, a diagnostic test completed by 3 months, and early intervention by 6 months. That being said, if we can do all of those things sooner than 136 months, we should. And really, the landmark study that really drove these guidelines for us was published in 1998 by Christine Yoshinaga Itano. I think I got it right. This is a study that all of us audiologists or anyone who works with these kids is very familiar with. And her research indicated that infants with hearing loss who received appropriate intervention services before 6 months of age demonstrated higher expressive and receptive language. Now, that language could be either verbal or visual. They had higher expressive vocabulary skills and better personal, social, and speech skills than children who were identified and receiving services later in life. So, regardless of the degree of hearing, whether it was a mild hearing loss or a profound hearing loss, they had the opportunity to develop language along with their hearing peers. Now, in 2017, the same author, Christine Yoshinaga Itanwa, published in Journal of Pediatrics follow-up study that only looked at expressive vocabulary. But in that study, she found that it's not only important to get that 6 month mark of being enrolled in early intervention, but if you miss the 1 or the 3, it also puts you at a higher risk for expressive language delay. So that being said, we know how important early intervention is. Early intervention is kind of umbrella term or services. So kids can qualify for early intervention for a lot of different reasons. Obviously, today we're going to talk about kids who are deaf or hard of hearing who qualify for early intervention services because of that. But when they qualify, they have access to a bunch of different therapies. Their development is closely monitored by professionals who come into the home, who work with families. If they find that there are speech and language delays, then they have access to speech and language therapy. If there are any motor delays or need for physical or occupational therapies, they also have access to that. And they have a teacher of the deaf who they have access to deaf mentors who can help them if the family chooses ASL. They have access to teachers who use listening and spoken language who will help mentor the family, teach the family about these very important developmental milestones. Children with hearing loss should be meeting 3 months of development within 3 months of time. And if they're lagging behind, then early intervention helps catch those families up. So we know how important it is, and there are incredible services that are provided to the family within their home from birth to 3 that they have access to. And we do really well with meeting our 1 and our 3 benchmarks. Early intervention can be more of a challenge. And I think that's where our pediatric community really can help us, is really encouraging families. If you have a child who qualifies for early intervention, who's been diagnosed with any type of hearing loss, unilateral, bilateral, mild to deafness, to really encourage your families to participate in the early intervention program because we know how vital it is for the success of that child.
In a nutshell, early intervention good, the earlier the better. Okay, all
Exactly.
right.
Exactly.
I can implement that. Albert, tell us a little bit about gene therapy. That's something you're involved in. What does it promise, and where are we?
Before I jump into that, I do want to emphasize one thing that I think Adrienne said that's really important, and that is that even a child with mild or moderate hearing loss, those children I think are just as important in terms of early intervention and treatment as those children with profound hearing loss. And I think that sometimes gets missed a little bit, that people sort of downplay the mild hearing loss. And I think Christy Yoshinaga's data really, I think, also importantly demonstrates the importance of early intervention. In terms of gene therapy, I think this has really been a revolution, a very exciting aspect of the hearing field, and it's been a game changer. I think it's something that's evolving, and I think as we know more about it, I think we'll learn a little bit more about sort of the benefits and limitations. But I think about 18 months ago or so is when the first clinical trials came out for a genetic mutation called otoferlin. There's probably several hundred different genes that can cause congenital or even acquired sensory hearing loss. And so they sort of went after with doing preclinical animal studies and then now doing clinical trials. They went after sort of the low-lying fruit. They wanted to look at a condition that essentially all the structure within the ear was present, but there was an area where they could sort of address it. That's what the studies are showing. Otoferlin is important for normal auditory function. It's a protein, the mutation is when that protein is absent. And yet, despite that, the otoacoustic emissions, the hair cells, the cochlear nerves, synapses are all present. And so this was, again, a low-lying fruit sort of condition that by using a adenoviral vector, where you essentially replace the protein that's absent, and you're able to inject that into the cochlea, the goal was to see if this may provide stabilization or maybe potentially improvement in these children with hearing loss. And so I think there have been about 25 or so children internationally who've undergone this treatment, and I think 24 of those 25 have shown improvement in their hearing. So it's been an amazing sort of trial so far. It's still ongoing. The first child was actually implanted or underwent the therapy at CHOP by one of my good friends, John Germiller. This was a child who I think was from Africa, who then was referred from a physician, I think maybe in Spain or from Europe. And that child went from essentially profound loss to mild hearing loss. And so to the point where he's aidable. It's not perfect, but again, these are children who would have probably undergone cochlear implantation, but this provides a alternative treatment that actually addresses sort of the cause or problem that's causing their hearing loss. Now, this is just one particular mutation. Probably accounts for maybe about 5% or so of all pediatric congenital sensory hearing loss. So, there's still a lot that needs to be done. But this is sort of a proof of concept where now, if we can determine the cause of the child's hearing loss, specifically if it's a genetic mutation, the hope is that in the future we'll be able to provide a gene therapy for that child. And so this is where it's an active area of investigation. This is where we're kind of reconsidering now, where children before we would recommend cochlear implantation. If they have an otoferlin mutation, we're actually recommending instead that they go into one of these clinical trials. And at least families are given the option that maybe they should consider this in lieu of cochlear implantation.
That's fascinating. What sort of timeline? I know it's always difficult to predict with science and technology. What sort of timeline are we looking at for that making a difference?
Well, the most common genetic mutation, the sort of holy grail that we're trying to go after is connexin 26. So that's the much higher bar because there we've oftentimes by birth or early on, there's already significant damage to the cochlear structures, specifically the synapses and the hair cells. But there's a lot of work being done on this. I think the next things that people might start looking at are other mutations where much of the cochlear apparatus is still present. And there are actually some that are known to cause progressively worsening hearing over time. So those might be the next candidates. But I think, and I wouldn't be surprised within our lifetime, that many of these genetic mutations will be treatable. This certainly has changed the sort of thought process where now we're really advocating for genetic testing for many of our children, just so that we can then provide more clarity to the families in terms of the etiology, a little bit more about the prognosis, because of some of these children we do know are at risk to develop progressive hearing loss. We also know that some children, like if they have Usher syndrome, unfortunately at risk to develop blindness or other conditions. But again, they also provide the hope that we can maybe treat these children with gene therapy and thus reverse this process.
Very fascinating. Well, let me just summarize what I've gotten over the last couple of weeks with a couple of overarching principles. One is that early testing and intervention is absolutely vital, that getting to these kids as quickly as possible, as thoroughly as possible, and then providing as much early intervention as possible in every way. It also strikes me that as a pediatrician, that pediatric providers are absolutely vital collaborators in this because we're the ones who see these kids on a regular basis. We're the ones who are following their development, who have a relationship with the family, and we can be absolutely vital in this, and it's important that we do that. You'd have mentioned several times that matters of public policy have made actual differences in the way we take care of kids, and being always mindful of that, I think, is absolutely vital. Thanks so much for your time over the last couple of weeks. I'm sure there will be a lot of questions. I hope you're willing to come back next week and answer some questions. Hope we haven't worn you out.
It's been great. Thank you so much.
No, this is something we could talk about even for more and more hours. But yeah, thank you very much for letting us be a part of this.
Yeah, this is fascinating. So thanks so much, Dr. Johnson, Dr. Park. Please send your questions at vcurb.com. Please recommend us to your friends and neighbors. Thank you to Elisa Stoddard, who makes this sound like a podcast. And thanks, Janice, for listening. We'll talk to you next week. Thanks for joining us. We look forward to getting together again next time. The virtual curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics. The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, the content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Elisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Production design, thanks to Paul Wirkus, who also composed the theme music. See you next time.